So the topic of this PowerPoint presentation is the WHO classification of myelodysplastic syndromes. And this is one of the topics from the Gillian Rosenberg training workshops. So the term myelodysplastic syndrome describes a state of abnormal bone marrow proliferation and differentiation, usually afflicting the elderly and in approximately 85% of cases culminating in acute myeloblastic leukemia. Pre-leukemia and smoldering leukemia were the terms used to describe this syndrome. So myelodysplastic syndrome results from the neoplastic transformation of a single pluripotent stem cell, leading to abnormalities in one or more of the erythroid, myeloid, or megakaryocytic cell lines in the peripheral blood and the bone marrow. So we'll now go through and discuss the changes that occur in all three cell lines. So in the peripheral blood, when we look at dyserythropoiesis, the features that you'll see on the blood film will be, it'll either be a normochromic normocytic anemia, but more commonly a macrocytic anemia, and it will be dimorphic. So you have two populations of cells, and the RDW, or the red cell distribution width, will be high. Also, you'll see the most common features you'll see in the red cells will be Pappenheimer bodies, which are iron granules, which I'll show you later. Then when we look at the bone marrow, we talk about dyserythropoiesis in the marrow, so we can see hyperplasia. We see megaloblastoid changes. I'll just explain the megaloblastoid. So they're the changes that you see in megaloblastic anemia. But this particular patient, for example, has come in with a suspect of being anemic and having a dimorphic blood film, and a B12 and folic acid will have been performed, also iron studies, and those results will be normal. So although you're seeing features that you see in a megaloblastic anemia, you know they're not megaloblastic. So the term that is used is megaloblastoid. So you get those changes, you get multinuclearity, internuclear and intercytoplasmic bridging, ringed sideroblasts, and irregular hemoglobinization of the red cell precursors, and also they'll have ragged cytoplasm. So this is a really nice image to show you just the variation in the red cell size. So you can see that there are some very large macrocytes around, and then some smaller microcytes. Okay, so this means that the red cell distribution width is actually very high. This is a nice slide which is showing you the Pappenheimer bodies in the red cells. So if we just concentrate again on the size of the red cells and the variation in size, there's a large macrocyte here, and then a smaller cell here. So you can see again, this patient has got a very high red cell distribution width. And of course, that means that the anisocytosis is increased. And these are the Pappenheimer bodies in the red cells, and they're usually groups and obviously more than one body. If you get a single body, you have to be careful that may be a Hal-Jolly body. But this red cell is a good example to show you there's a whole lot of small bodies which are staining a mauve colored, and these are Pappenheimer bodies. So this is iron granules that's not been incorporated into the hemoglobin. So now these are some of the megaloblastoid changes seen in the red cell precursors. So if I show you, point to this particular one. So this is a red cell precursor, and it's actually a polychromatic erythroblast. So it's gone through the very basophilic. So this one here is a basophilic erythroblast, but this one's much more what I'm trying to show you. This cytoplasm has gone through being basophilic to polychromatic, so it's starting to acquire hemoglobin. But if you look at the nucleus, it's very immature and primitive. So it's lagging behind in the maturation process compared with the cytoplasm. So this is classically a feature of dyserythropoiesis. So an open chromatin pattern in the nucleus, demonstrating it's very primitive, but the cytoplasm is much more developed. So the two are not synchronized, and this is why we call this is what we see in megaloblastic anemia, but this patient doesn't have B12 or folic acid deficiency. So this is showing dyserythropoiesis. And we talk about this as being megaloblastoid changes. Now, if we look at this red cell here, red cell precursor, this one here has also got some budding of the nucleus, which is actually also a feature of myelodysplastic syndrome. This is a really nice film showing you, but this is in the bone marrow and showing you those megaloblastoid features in the red cells. Here we see again similar, what I was just showing you in that last image. Here we can see that this nucleus is almost like bilobed, which is a feature, budding, bilobing. Look at these nucleated red cells here, which are more developed, but house their cytoplasms incomplete, so they're not fully hemoglobinized. We can describe that as having ragged cytoplasm, another feature classically of myelodysplastic syndrome. This one here as well, and this one here. They're not normally, should not look like this in a normal bone marrow. So these are megaloblastoid features again. This is really the pièce de résistance of a red cell precursor that is dysplastic, very dysplastic. The nucleus is primitive, very immature compared to cytoplasm, which is significantly developed. It's at the polychromatic stage. The next stage would be the orthochromatic, where it's starting to acquire more hemoglobin and look a little bit more pink. But this is classically a megaloblastoid, feature you see in the red cell precursor. This is a peripheral blood film, and this shows a nucleated red cell, which has got certainly budding of the nucleus. So that feature in itself makes you want to look further around. Basically, this is definitely showing megaloblastic or megaloblastoid features. I'll just tell you about this film. This was from a 14-year-old child who'd come from another state. She had the very uncommon myelodysplastic syndrome in a 14-year-old child, very rare, and she was coming for a bone marrow transplant. Again, another example. I'm showing you lots of examples. So I just perhaps should say to you at this point in time that myelodysplastic syndromes, most of this talk comes from the 4th edition of the WHO classification of myelodysplastic syndromes. It was written by in the actual WHO book was written in 2008. It has now been superseded or revised in 2017, and it's known as the revised 4th edition. Unfortunately, these workshops have been going for quite some time, and so the categorization of the different classification that I'm showing you in this workshop is from the 2008 edition. So if some of the people who are studying this may be registrars, please be mindful that the groups I'm going to describe in myelodysplastic syndromes are from the 2008 edition and not the revised 4th edition. It's unfortunate that the WHO book actually gets rewritten every 8 years. So to be quite honest, anybody who has written a textbook and followed the WHO classifications in the various disorders, their book is out of date practically after 8 years, which is a shame, but that's how it is. But these workshops are really designed for scientists to be able to recognize the features of a patient that has got myelodysplastic syndrome, and important to take into account the fact that they're an elderly patient and got all these classical features in the peripheral blood and the bone marrow. And if we can recognize those features, then we're very capable of recognizing features on our blood film morphology on different patients that we may have. So also when you're looking and trying to make a classification or a diagnosis, you need to look at the history, you need to look at the age of the patient. That's very important. I say that with some conviction because I'm working in a children's hospital with perhaps a third of the samples that we get every day will be pediatric patients. So yeah, age of the patient as well as the clinical history is very important. Just go back again to this another bone marrow to show you some more features. Looking at these two nucleated red cells, their cytoplasm is not fully hemoglobinized, so it's got that ragged cytoplasm appearance to it. Here's another red cell, which is a polychromatic erythroblast, but the nucleus is still a little bit open and immature, so it's showing asynchronism. It's not in synchronization. These are two white cells, which we'll talk about in a second, but these are two neutrophils, and they're very abnormal. If you look at the chromatin pattern, they're quite dense, and there's a term that New South Wales Health will use to describe this, and it's pseudopelgaroid or pseudopelgahuae. I like to use the term pelgaroid, and it depends what you want to use, but you need to recognize that it's not normal and it's a feature of myelodysplastic syndrome. Now, the other thing that we mentioned was the cytoplasmic bridging. So if you look carefully on this PowerPoint, you'll see that there is a very fine bridge of cytoplasm linking these two erythroblasts. So cytoplasmic bridging, mainly seen on the bone marrow, can be seen on the peripheral blood, but mainly on the bone marrow. And again, here's two really abnormal neutrophils, which we'll talk about in a second, showing pseudo-pelgaroid or pelgahuae features. And here are the ring sideroblasts. So this is an iron stain. So this comes from a Prussian blue stain, which is the stain used to stain iron granules in the bone marrow. And what we're looking at are ringed sideroblasts. So these are all erythroblasts here, which have got granules of iron surrounding the nucleus, situated in the mitochondria. And to have a true definition, or for that to fit the criteria, you have to have 5 or more of these iron granules covering at least 1/3 of the nucleus. And there have to be about approximately 15% of the erythroblasts in the marrow have to have these ring sideroblasts present. So that's actually a beautiful picture, the classical picture of sideroblastic anemia. So now let's talk about the changes you get in the white cells, namely the neutrophils or the myeloid line. And again, the term dysgranulopoiesis is used. So in the peripheral blood, we see neutropenia in 50% of cases, approximately 50%. We see a monocytosis. So that's also one of the first things that might alert you to the fact that you've got an elderly patient with a high red cell distribution width, and then a monocytosis. And then you should go and look for all these other features that we're going through. So monocytosis, hypogranularity, and agranularity of the myeloid line. So a reduction in granules in the cytoplasm in the neutrophils, and some neutrophils will have no granules, so A meaning without granularity. We'll see abnormal nuclear morphology and we'll see pseudo-pilgaroid changes, which I have just shown you a couple of examples. Looking at the bone marrow, so dysgranular poiesis in the bone marrow, the things that we would look for is hypercellularity, again the monocytosis, hypogranularity and agranularity of the myeloid line, and we may see some increase in the blast cells, and they may have some owl rods present. We'll see a lack of mature forms, and we'll see giant metamyelocytes. So those of you who are very au fait with what you see in a patient with megaloblastic anemia, giant metamyelocytes are a feature of true megaloblastic anemia, but you can see these in myelodysplastic syndrome as well. So now we're looking at the myeloid line. This is the peripheral blood, and we're looking at two neutrophils, which are agranular. So if you look at the cytoplasm, there are no granules in the cytoplasm at all. And looking at the nucleus, it's really very dysplastic. It's, if you want to call it pseudo-pilgaroid, I like my term pilgaroid. So it's very abnormal, classically only seen in myelodysplastic syndrome. Here's another image, again of the peripheral blood. And this is hypogranular. Or these two here I'm pointing to are hypogranular. And this is these two are agranular, pardon me. These are agranular and this is hypogranular because there are some granules here, but not the normal number. And the nuclei are very dysplastic. So this is an amazing film. I remember this film very well. This is a neutrophil. This patient had myelodysplastic syndrome, and every neutrophil on this film was like this. This is not a myelocyte, okay? It's not a myelocyte. It's a very dysplastic neutrophil with a round nucleus. So you have to count these cells as myelocytes. And if you just want to have a look at the background of some of these images I'm showing you, you can see that there are some very large macrocytic red cells and some cells also that are not necessarily microcytic, but almost verging on being microcytic. So if you put this cell here, which is a bit microcytic next to this macrocyte, you'll see that that RDW is very high. So we've got the features of the myeloid changes plus the red cell changes in this film. Now moving to the megakaryocytes. So in the peripheral blood, we've got dysmegakaryopoiesis. So we can see mild thrombocytopenia in about 25% of cases. The platelet anisocytosis will be significant. So we'll note that there's a raised mean platelet volume and a platelet distribution width. So we'll see giant forms, giant and large platelets. We'll also note that there's abnormal granulation in the platelets. So some may be a bit hypogranular. Some may have perhaps a little bit of extra granulation, but abnormal granulation will be a feature. And you may sometimes see megakaryocytic fragments on the blood film. So going to the bone marrow, dysmegakaryopoiesis in the marrow. There'll also be a mild thrombocytopenia in about 25% of cases in the marrow. And the megakaryocytes will be hypolobulated and micromegakaryocytes. So they'll have a reduced number of lobules of the nucleus, and they can be quite small. The megakaryocytes can be small or micro. We'll also see non-lobulated nuclei in megakaryocytes of all sizes, and then megakaryocytes displaying nuclear separation. And that means that there'll be a lot of lobes to the nucleus in the quite large megakaryocytes. So looking at this blood film, this is another alert sign that when looking at this film, it's not so obvious that there's a red cell, that the red cell distribution width is very significantly raised, but I'm looking at the platelets, and this platelet here would be about the size of a normal platelet. Remember, these films that I'm showing you are taken under oil immersion, so they're actually 1,000 times magnification. So that's about the size of a normal platelet. There are some large platelets. That's a large platelet there. This is another, perhaps a large platelet here. And there are some giant platelets. This is a giant platelet, and it depends what you want to call it. Perhaps that's a giant, but this is large. So the definition of a large platelet is a platelet that is large but smaller than the red cell. Okay, smaller than the red cell. And a giant platelet is a platelet which is very large and bigger than the red cell. And when you comment on large and giant platelets, you need to be mindful of the fact that it should be a salient feature. You might just happen to see a really large platelet in a normal film. And it doesn't mean to say that you're looking at a myelodysplastic syndrome. It has to be a salient feature before you comment on it. And after all these workshops, you'll know exactly the types of disorders where you can get platelet anisocytosis. And it's not only myelodysplastic syndrome, some of the myeloproliferative disorders. So again, looking at your age, is there monocytosis? Yes. Do I see pyrgoroid neutrophils? I see large platelets. So all of this and giant platelets, this all goes to make up, yes, I'm looking at a patient who has got a myelodysplastic syndrome. This is the megakaryocytic fragment. This can be a little bit controversial. So I thought that this was a fragment of the nucleus of a megakaryocyte, which is broken off and circulating in the peripheral blood. You can see some Pappenheimer bodies in the background here. Pappenheimer bodies here, some here. This, I think, is a Hal Jolly body. It's a single, the last remaining amount of DNA of the nucleus, but it's going to always be a single body. When you get them in multiple bodies or very small like that, they're Pappenheimer bodies. Here we have a hypolobulated megakaryocyte. So these will be found towards the end of the film in the bone marrow, perhaps not in the peripheral blood, but in the bone marrow. Because they're large, they'll go to the end of the film, so you can look at the end and see what the megakaryocytes look like. So this is hypolobulated. It's just got one lobe to the megakaryocyte. This is the hyperlobulated. So this has got a number of lobes. This is a huge megakaryocyte. You can see that it's even bigger than, it was too big to fit into the actual image. And so just something to be mindful of, that megakaryocytes, when they mature, the process that they mature by is known as endomitosis. And that means that one lobe divides into two, two into four, four into eight. It's a classical maturation of a megakaryocyte. Usually it stays much the same size while it increases in lobes of the nucleus. So now we're going to talk about the different categories. So this is where we scientists don't get too worried, and this is where this comes from, the 2008 version of the WHO. The 2017, so the 2008 is entitled the 4th edition, and the next edition, which came about 8 or 9 years later, was the 2017. And if you look at it carefully, it says the revised 4th edition. So we haven't had a 5th edition yet. So the WHO classification divides these syndromes, the myelodysplastic syndromes, into 7 groups, according to the number of myeloblasts and ring siderocytes in the peripheral blood and the bone marrow. So refractory site, I'm going through the 7 groups. So refractory cytopenia with unilineage dysplasia, refractory anemia with ring sideroblasts, refractory cytopenia with multilineage dysplasia, and refractory anemia with excess blasts. Now, in case any of you are not too sure of the term refractory, it basically means does not respond to treatment. Then the next group is the myelodysplastic syndrome with an isolated deletion of 5q, a chromosome specific to this particular group. There's myelodysplastic syndrome, unclassifiable. And then the very rare one that I showed you that peripheral blood film from is childhood myelodysplastic syndrome. So refractory cytopenia with unilineage dysplasia. Just if we're registrars, just be mindful of the fact that this has been superseded now, these groups. So refractory anemia with unilineage dysplasia includes 3 groups: refractory anemia, refractory neutropenia, and refractory thrombocytopenia. So refractory anemia, it affects mainly the red cells. The neutrophils and the megakaryocytes are normal, but may show mild dysplasia. They're elderly patients presenting with anemia. They have an increased anisocytosis, so they have a dimorphic red cell picture with an increase in the red cell distribution width. You see dysplastic red cell changes in the bone marrow. And when you look carefully, you'll see that there's less than 1% blasts in the peripheral blood and less than 5% blasts in the bone marrow, and less than 15% ring sideroblasts in the bone marrow when stained with the Prussian blue stain. So cytogenetics. There are no specific cytogenetic abnormality in refractory anemia. The cytogenetic abnormalities that may be present in up to about 25% of cases are as follows. So there are 4 classical cytogenetic abnormalities. The first one is a deletion of chromosome 5, or minus chromosome 5, deletion of chromosome 5, and in about 50% of cases. The next one is minus chromosome 7 and deletion chromosome 7 in about 10 to 15% of cases. Deletion of chromosome 20, 22 in 5 to 10% of cases, and a plus chromosome 8 in about 20% of cases. So we also would do immunophenotyping if it was relevant, but immunophenotyping is not indicated in the diagnosis of refractory anemia because there are not enough blast cells. I'm going through now to show you some more images. I think the more images that you look at, the more you'll be really confident that you can pick these disorders, having studied these workshops. So just showing you the high red cell distribution widths. So if we just look at this red cell here, which looks macrocytic, and look at the little red cell sitting beside it, the RDW on this patient is significantly high. And I'll just remind you of some of the very early workshops that the Royal College pathologists and AIMS used to do for scientists on a yearly basis. I remember one of the speakers who was one of the early speakers on myelodysplastic syndromes, and he said, when I see this large macrocyte with this microcyte sitting next to it, I know that this patient's got myelodysplastic syndrome. It's something I've never forgotten. So I should just tell you, hopefully you won't forget it either. Now looking at refractory neutropenia, it's characterized by approximately 10% dysplastic neutrophils, seen both in the peripheral blood and the bone marrow. Nuclear hypolobulation, so reduction in the number of lobes of the nucleus, and hypogranulation, reduction in the number of granules in the nucleus. They're the most prominent features or dysplastic features seen on the blood film. And refractory thrombocytopenia is characterized by approximately 10% of dysplastic megakaryocytes. And according to the WHO, you have to count at least 30 megakaryocytes and see these changes in 30 separate megakaryocytes. So dysplasia in the form of hypolobulated and hyperlobulated megakaryocytes, as well as micromegakaryocytes, are a feature. So moving to the next group, which is refractory anemia with ring sideroblasts. It affects mainly the red cell series. So you get an increase in the anisocytosis and RDW. So you get what you call a dimorphic red cell picture. You'll see basophilic stippling and Pappenheimer bodies. Now I mentioned as the most classic feature Pappenheimer bodies, but you can actually see other features as well, which are not quite as common. So basophilic stippling, and approximately 15% of ring siderocytes or sideroblasts with the pearl Prussian blue stain, and that's seen on the bone marrow. Then you'll see dyserythropoietic changes in the bone marrow. You won't see any blasts in the peripheral blood or the bone marrow. Platelets may be large with a high mean platelet volume and a high platelet distribution width. So just going through that again with the refractory anemia with ring sideroblasts, no blasts in the peripheral blood, no blasts in the peripheral blood, and less than 5% blasts in the bone marrow. So re-cytogenetics, again, no specific cytogenetic abnormalities been identified in refractory anemia with ring sideroblasts. If there are cytogenetic abnormalities present, they'll be present in about 5 to 10% of cases involving a single chromosome. And of course, immunophenotyping again is not relevant. We would do immunophenotyping when we start to get a lot of blasts, because this is probably meaning that this myelodysplastic syndrome is transforming to acute leukemia, but it's not relevant in this group because there are not enough blasts. So this is a nice image of a case of someone with refractory anemia with ring sideroblasts, and again showing you the increase in red cell distribution width and the Pappenheimer bodies. I should perhaps at this stage just explain to you that the Pappenheimer bodies are iron granules that's not been incorporated into the hemoglobin molecule. When they're stained with the Romanowski stain, they're then termed Pappenheimer bodies. These granules of iron in the marrow, when stained with the Prussian blue stain, are called siderotic granules. They're one and the same granule, but they have a different nomenclature according to the stain, be it Romanowski or be it Prussian blue stain. So now these are a tiny bit more difficult to look at. And scientists generally won't have to do this, but this is a bone marrow of someone with refractory anemia with ring sideroblasts. And if you look at the red cell precursors, I think you'll see the features that I've already just explained to you previously, the dyserythropoiesis and the variation in the maturation process between the nucleus of the red cell precursor and the cytoplasm. So these are two ones here, very dysplastic. Some of these more mature red cell precursors have got ragged or incompletely hemoglobinized cytoplasm. So I'm just trying to show lots of different examples just to make sure it's all fixed in your mind. This is a very immature mitotic figure. Again, here's your refractory anemia with ring sideroblasts and your siderotic granules covering the actual blast cell. So you have to have at least 5 of these granules covering about 1/3 of the nucleus. And it has to be 15% of the seen in the bone marrow to put it into this category, refractory anemia with ring sideroblasts. So moving on to the next category, which is refractory cytopenia with multilineage dysplasia. And it's characterized by 1 or more cytopenias. So you get dysplasia in 2 or 3 cell lineages, the erythroid, the granulocytic, and the megakaryocytic. And you get less than 1% blasts in the peripheral blood and less than 5% blasts in the bone marrow. The monocyte count is less than 1/10⁹ per liter in the peripheral blood. And you get plus or minus 15% ring sideroblasts in the bone marrow. So the cytogenetics, no specific cytogenetic abnormality, but those that occur can be present in up to 50% of cases. And if you note, as we go through all these groups, you'll note that the same cytogenetic changes are occurring. So minus chromosome 5 deletion chromosome 5q, minus chromosome 7 and deletion of chromosome 7q, deletion of chromosome 20q, and an additional chromosome 8. I'm not into cytogenetics, but the Q is the long arm of the chromosome, and the P is a short arm, and the P stands for petite, which is French for small. I'm not too sure what the Q stands for, but it's the long arm. Again, not enough blasts, so immunophenotyping is still not relevant in refractory cytopenia with multilineage dysplasia. Here's another blood film from another patient. Look at that macrocyte there. Look at that microcyte there. I'm going to look at the age of this patient, and I'm going to scan the film to see what the monocyte count is. It's going to give me a big hint that this patient has got a myelodysplastic syndrome. And sometimes, you know, these patients just come into hospital. They're elderly. They may know that they're not feeling too well, but they don't do anything till they're really very feeling unwell and just turn up in hospital. When you check, has this patient been in, go into the medical record number and check whether they've been in hospital before, you find that they're a completely new patient. And that's often the case. Here again, variation in the cell size, and look at this neutrophil. It's very dysplastic. It's got a slightly budding shaped nucleus. It's hypogranular. It's telling me that this patient has got myelodysplastic syndrome. And this is unusual because this is actually on the peripheral blood film. But I just had to take this photo because you can see this is a beautiful example of cytoplasmic bridging between 2 quite dysplastic neutrophil precursors. See how this is all budding and not nice and round and smooth. So these are classical dysplastic, these are red cell precursors, these classic with the cytoplasmic bridging. They're not neutrophils, sorry. So now moving to the next group, which is refractory anemia with excess blasts. characterized by unilineage or multilineage dysplasia, so more than one cell line sometimes. Refractory anemia with excess blasts is divided into two subgroups according to the number of blasts in the peripheral blood and the bone marrow. So refractory anemia with excess blasts in group 1 has 2 to 4% blasts in the peripheral blood and 5 to 9% blasts in the bone marrow. And refractory anemia with excess blast group 2 has 5 to 19% blasts in the peripheral blood and 10 to 19% blasts in the bone marrow. Just note that we stop at 19 because if we get to 20 blasts, that means we've got acute leukemia. Looking at the cytogenetics, again, no specific abnormality, but these are the cases that occur in about 30 to 50% of cases. And again, it's the same chromosomes keep reoccurring. So it's easy to remember. Now, in group 2, where we've got up to 19% blasts, I think immunophenotyping would be relevant. And so what we're doing here now is showing you the myeloid CD markers. So CD13 and CD33 are myeloid markers, and your CD117 is a progenitor of the myeloid line. And looking at the bone marrow, I'll just try and find you some more of the same things. Not too sure what this is, but it's bilobed. I'm sure it's probably a nucleated red cell with bilobed, very bizarre looking. These red cell precursors here have got ragged cytoplasm, incompletely hemoglobinized. This is a myeloid cell, as is this one, with very, very pycnotic chromosome pattern and hypogranular, or actually not hypo, but agranular cytoplasm. So it's got features of the red cell precursors and the myeloid line, which are all dysplastic. And look at this neutrophil. It's very, very dysplastic. This is not my best film. I didn't really want to use it because this is a bone marrow. That's not such a perfect marrow, but I had to put it in because this is a red cell precursor with 2 buds on the nucleus of the red cell precursor. And this is a classic feature. I can hear some of the hematologists when I go to some of their sessions to look at marrows, which I usually do once a week, when they see that, oh yes, this patient's got myelodysplastic syndrome. That's classical. And another bone marrow to show you. This is a bit more tricky, but I think you can see that there's the maturation between the nucleus and the cytoplasm is quite, it's not synchronized, it's out of synchronization. So it's dysgranular poiesis. Now, interestingly enough, the WHO puts this group known as myelodysplastic syndrome with isolated deletion 5q in the middle of these syndromes. And I think it's in an unusual position, but this is how it does it in every edition of the WHO book. So this is a single chromosome, 5q. It affects mainly the red cell precursors and the megakaryocytes. And the patients present with a severe refractory anemia. They have dysplastic changes in the red cells. They can be variable. Platelet count is either normal or increased. And the megakaryocytes are hypolobulated and either normal or increased in number. They have a leukopenia with less than 1% blast in the peripheral blood and less than 5% blast in the bone marrow. So you see, we've now got in the middle of these groups a case of myelodysplastic syndrome with isolated deletion 5q with a lower blast count. So associated with an isolated deletion of 5q, this is very important to remember this, it's only one chromosome's deletion, it's not a minus 5q, it's just a deletion of 5q. So should there be any other cytogenetic abnormality, the case should not, that's why that's in uppercase, be included in myelodysplastic syndrome with isolated with deletion of 5q. So only deletion of 5q. Okay. So minus 5q and deletion of 5q is a completely different syndrome. This is some little bit of extra bit of information that the size of the deletion and the breakpoints may vary according to the particular band. So 5q in position 31 and 5q in position 33 are invariably deleted in the 5q myelodysplastic syndrome. Immunophenotyping is not relevant because we don't have enough blasts. So the term 5q syndrome is being used to designate a subset of cases with a macrocytic anemia, normal or increased platelet count, and bone marrow erythroid hypoplasia with less than 1% blast in the peripheral blood and less than 5% blast in the bone marrow. So it is unique, especially the chromosomes will tell you that. It stands out, and I understand that it responds very well to treatment. And if you had to have this syndrome, probably this would be the best one to have. Again, and not such a good marrow. It's a bit of an artifact in this, but just even overlooking that and looking at the dyserythropoiesis in these red cell precursors, looking at this neutrophil here and this one here, looking at the very dense chromatin pattern of the nucleus, this one as well. Very abnormal, telling me this patient has got a myelodysplastic syndrome. This was an unusual slide that I found, which is a red cell precursor with 1, 2, 3, 4, 5, 6, maybe 7 lobes. And it was in a patient who had isolated deletion 5q. So now moving to the next group. The next group is myelodysplastic syndrome unclassifiable. So it's a subtype of MDS made up of cases which do not qualify for any of the other major categories. So myelodysplastic syndrome unclassifiable is divided into 3 groups. The first group is made up of cases with characteristic findings of refractory cytopenia with unilineage dysplasia, or refractory cytopenia with multilineage dysplasia, but with only 1% of blast in the peripheral blood. The second group, cases of myelodysplastic syndrome with unilineage dysplasia, but which present with pancytopenia. Refractory anemia with unilineage dysplasia, which we talked about in the beginning, only allows for a single cytopenia or bicytopenia. Here we've got pancytopenia, so all 3 cell lines may be affected. And cases with persistent cytopenias with 1% or less blasts in the peripheral blood and less than 5% in the bone marrow, and who have also cytogenetic abnormalities associated with MDS. So there's no specific cytogenetic abnormalities in this group, the unclassifiable group, and immunophenotyping, again, is not relevant because there's not enough blast cells. So now we're moving to childhood myelodysplastic syndrome. It's a very rare condition in children. It's so rare that if you think of this, it comprises less than 5% of all the hematopoietic neoplasms in patients under the age of 14 years. So it's very rare. That's why that young 14-year-old child came over from another state to have a transplant at the Sydney Children's Hospital, at Prince of Wales Hospital. So de novo MDS of childhood. So de novo means a first presentation. Nothing else has triggered it off. They haven't had any chemotherapy. It's a de novo MDS of childhood. Should not be confused with a secondary MDS, which is associated with acquired bone marrow failure syndromes or MDS, myelodysplastic syndrome, following the use of cytotoxic agents. So patients, both adults and children, especially children who are being treated with cytotoxic agents, for example, children with acute lymphoblastic leukemia, of which we get a lot of those cases at the Sydney Children's Hospital, are treated with methotrexate, which is the cytotoxic agent, which actually leads to, after multiple doses of methotrexate, leads to dysplastic changes in the peripheral blood and the bone marrow. So knowing the clinical history, as I said initially, is very important. We need to know the history of the patient, and we need to know if they have these changes. Perhaps they do have acute lymphoblastic leukemia, and so you know really not to report those changes because you know why they're there. Perhaps at this point I should say, it's a bit of an idiosyncrasy of mine, but a good one to have, all of you. When you have clinical diagnosis, which you know is the right diagnosis, not just necessarily reported on the report or on the reports that the doctor has issued for you, on the bone marrow report. If you see the bone marrow report and the diagnosis, the changes in the diagnosis, and you see that the patient has got, say, myelodysplastic syndrome or multilineage or refractory anemia with excess blasts, you should put that into your patient notes in your computer. Because if you're really, what I would say, really switched on, good quality scientists, you need to look at those notes and you need to have a history. Clinical history is very important. Sometimes the history written on the request form might not necessarily be 100% correct. So if you take it from the bone marrow report, put it into the patient notes, it'll stay there forever. The episode notes would be just for things that are happening from time to time, but the patient notes will be there forever, and you should then be able to realize that they are the right diagnosis and then look at your film with that in the back of your mind. So in the childhood, cytopenia, refractory cytopenia of childhood is characterized by persistent cytopenia with less than 2% blasts in the peripheral blood and less than 5% blasts in the bone marrow. So the dysplastic features seen in both the peripheral blood and the bone marrow of children are similar to those seen in the peripheral blood and bone marrow of adults. So that ends the topic of myelodysplastic syndromes. Just remember that it does follow the category of the myelodysplastic syndromes from the 4th edition of the WHO textbook, which was published in 2008. And for any registrars who are looking at this talk, perhaps keep in mind that the new edition, which is known as the revised 4th edition, which came out in 2017, has made some subtle changes to the groups. But the idea of these workshops is especially for the scientists to be able to recognize the classical features seen in both the peripheral blood and the bone marrow of, keeping in mind, elderly patients who have got a monocytosis. That would be a trigger for you to start to look. And remember, comment on the salient features. Salient means the features that are classical and that you see from field to field when you move around on your blood film and you keep seeing the same features, then report them. So don't report on features that are just, you just see one giant platelet on an otherwise normal film, don't suspect, or don't report it because it's not significant. So thank you very much for your attention.